Thank you, Dr. Richa, Dr. Alok. I could see General Prasad here. Yes, Professor Suryakant, Professor Rajendra Prasad and friends. During the next few minutes, I will like to talk to you about the management of drug resistance TB. Just to give you a brief outline about the global and the national magnitude of TB and the drug resistant TB. You know, I have tried to show you about the global TB report 2021. You know, the 22 report is to be released after about 2 to 3 days, including our own national tuberculosis report. And then again, you can see on the right hand side, I have given you the figure of 2019. This is because in 2020, because of COVID, we have got a figure, but they are not the actual reflective figure. So I have just tried to give you the picture for 2019. You can see in the world in 2019, we have nearly 10 million new cases of TB. And on the other hand, if you see in the right side in yellow, you can see we had detected about 26.4 lakhs or 2.64 million new cases of TB. Coming to the last line, that is the multi-drug resistant TB, about 4.65 lakhs in the world, and in India, it was estimated that we'll have around 1.24 lakhs of MDR TB, that is constituting about 27% of the global burden. So our own India TB report 2021-22 will be released day after tomorrow. And again, you see the case detection rate from 27 to 28 to 29. As you can see, the topmost figures, both from the private as well as the public sector, it was gradually increasing from 18 lakhs to about 24 lakhs. We are doing well as regards the notification. But what happened in 2020, because of COVID, you see the number, there was a sudden drop. So that is the, unfortunately, that had happened. For 2021 till December 21, we could detect about 21 lakhs. If you see the last row, that is about 21 lakh 45,000 cases against an estimated case load of 29.94 lakhs. So this is only 72% of the estimated number. They could be notified, but still it was a good job in comparison to 20, despite there are a COVID during some parts of 21, still we could achieve a large number of notification. Coming to the resistance, drug resistance in tuberculosis, you see, we know that we have got a larger population. That is, you see that graph. Is there a pointer or something? Can I get a pointer? Pointer hai to dekho, ek pointer dena. If you see the larger one, most of them are drug sensitive TB. Then we have got a group of patients who will have a mono-resistant TB, that is resistant to one of the first line drugs. And then we have got a multi-drug resistant TB when resistance to at least isoniazid plus rifampicin, that is called multi-drug resistant TB. And there is also now a new term has been added, that is RR-TB or rifampicin resistance TB, because by way of doing the CBNAT testing, if there is rifampicin resistance, then it is called RR-TB, which is almost same as that of the MDR-TB, because whenever there is a rifampicin resistance, there will be, by and large, from a clinical point of view, there will be associated INH resistance. Then the two other terms, that is pre-XTR-TB and XTR-TB, or extensive drug resistant TB, here the definition has changed from January 2021. Earlier, it is a form of multi-drug resistance TB, that is resistance to INH and rifampicin or rifampicin resistance. But in addition to that, earlier definition was to resistance to either to a fluoroquinolone and a second line injectable. Because of the new classification of the drugs, which will come a little later, so now the definition has changed to XDR TB, that it is caused by Mycobacterium TB, that is fulfills the definition of MDR TB or rifampicin resistant TB. that are also resistant to any fluoroquinolone and at least one additional group A drug. I'll tell you what is a group A drug. Group A drug, the another two drugs are linezolid and Vidaquilion. Remember, so now it is MDR-TB and also resistance to fluoroquinolone and one either Vidaquilion or linezolid or even it can be both. Right, so this is the new definition from January 2021. The anti-TB drugs have been used for decades and strains that are resistant to one or more of the medicines have been documented in every country where survey has been done. So these drug resistance emerge when the anti-TB drugs are used inappropriately or when there is a incorrect prescription by the healthcare providers or when the drug quality is very poor and when the patient stops the treatment prematurely before completing the therapy. So these are the some of the, in summary, the common causes of drug resistant TB. It may be because of the microbial issues or it may be programmatic issues even. In the microbial issues, we have got genetic mutation which is caused by random chromosomal mutations at predictable frequencies. Say for example, INH resistance bacilli in a natural strain 1 in 10 to the power 6 bacilli will be naturally resistant to INH, and similarly for rifampicin it is about 1 in 10 to the power 8. So therefore resistance to INH and rifampicin will be 1 in 10 to the power 14. This is the simple mathematics. So actually in a cavitary population this huge number of bacilli is not possible. So therefore naturally occurring rifampicin resistance is virtually impossible. Although it is possible, what I should say, from clinical point of view it is impossible. So therefore whatever resistance we see, they are because of other reasons, they are man-made issues. Then I had already told you because of drugs, when there is inadequate supply, poor quality, non-availability of certain drugs, like when there is a stock out, when there is a poor quality, there is a poor storage condition, when there is a wrong dosage or combination is given, or when there is a unsupervised treatment, when there is absence of guidelines or inappropriate guidelines, non-compliance with the guidelines, inadequate training of the health staff, no monitoring of treatment, poorly organized or funded TB control programs, or when the patient does not take intake, that is unobserved treatment, poor adherence, lack of information, non-availability of free drugs, adverse drug reactions, socio-economic barriers, malabsorption, then substance abuse like alcoholism, etc. So these are some of the important causes why drug resistance in TB develops. So this is just a slide that shows the drug resistance mechanism, that in the bacillus it happens, it can either through the flux pump, meaning there will the drug is entering into the cell, but again it is because the bacteria then it throws it out, then there are drug inactive enzymes produced by the mycobacteria, or they can be modified cell envelope proteins or lipids, or there may be modified drug targets. So these are some of the important mechanisms why drug resistance. So this is a complicated one, and how it happens you can see it can occur at various levels, as I have told you. So from the clinical point of view, some common targets of chromosomal mutations, they are conferred drug resistance in the Mycobacterium tuberculosis. You can see we have certain genes are identified which are almost, if they are present, it is almost identical that it is resistant. Say for example, for rifampicin, it is RPOB gene. For INH, it is CAT-G, INHA gene, or the INHA promoter gene. For ethambutol, for every drug, I am not going to read you one by one. Almost for every drug, then a gene has been identified. You can see for injectables, for fluoroquinolones, similarly for the PAS, cycloserine, linezolid, even the newer drugs which have just introduced, that is Vidaquilion and the Delevanate, we have got targeted genes, and if they are present, then they are likely to be resistant. So as I told you, drug resistant, as you could see, it is a consequence of ineffective treatment at the individual level. When antibiotics are improperly selected or taken, and when you don't follow the algorithm of treatment. If you go back to the global burden of TB in 2019, I have shown you about 10 million new cases per year, and then out of that about 500,000 or 5 lakh new cases with MDR or rifampicin resistant TB will be there. Then therefore the accessible drug susceptibility test results are critical throughout to make accurate diagnosis, to treat them appropriately, and it is important therefore to reduce the diagnostic delay, and then it is linked more patient to the care. Unfortunately, 1/3 of new TB cases go unnotified, undiagnosed, specifically in case of drug-resistant TB. In the world, over the years, you see the number of people treated for drug-resistant TB, it is fell by 15% from 1,77,000 in 2019 to about 1,50,000 in 2020. So that is equivalent to only about 1 in 3 of those in need. The treatment success rate for drug-resistant TB is around 60% globally, and that is very low. So these are some of the important issues.
India accounts for about 57% of the total global India cases. So the efforts are delayed with COVID-19 pandemic. Therefore, drug-resistant TB is one of the biggest hurdles in ending TB by 2025. Limited scope of safe test and with approach the drug-resistant TB population are available
in 2 hours or so, but it is not yet possible fully for all cases. Then monoresistance to INH, it is a growing concern, and only 8% of those they get detected. So this is what shows the summary in India of the estimated 2.7 million new cases of TB. We have got almost 450,000 or 4.5 lakh deaths, and around 130,000 people will be notified with drug-resistant TB, and this is nearly 27% of the total global drug-resistant TB burden. And only out of this number, you see, 46,000 they could be started on second-line drugs. So this is what is the tragedy of drug-resistant TB. Not only in our country, it is also many parts of the world. So even if we have got existence, we could not diagnose. Whatever we diagnose, we could not put them on treatment. Even we treat them, you see the success rate is not very high. So that is the grim situation about drug-resistant MDR TB in particular. This slide I have already told you. This is in 2020. We have got around 124,000 or 1,24,000 MDR TB cases. That is about 27% of the global burden. That is almost 1/3 of the global MDR TB is in India. The other countries are China, Russia, Pakistan, Indonesia. They to some extent they contribute. So India in that way is the MDR TB capital. We have got periodic drug resistance surveys in India for MDR TB, and there we have got the estimates over time. We have got data from 2000 to 2001, and the latest data that I'll just show you that was done between 2014 to 16. So this is one of the largest DR surveys or drug resistant TB surveys in the world. We selected 120 sites covering about 1.25 billion population, and you see we have got information about drug resistance pattern to these 13 drugs, the important 13 drugs you can see. So what we found, we found that any drug resistance, the new cases about 22.54%. For previously treated cases, it is higher to the tune of 37%, and overall around 28% of all TB cases will be resistant to any TB drug. Again, the next column you see MDR, it is around 2.84% of all new cases will be MDR TB, and previously treated cases around 11.6%, and overall the figure is around 6.1% of all TB cases will be MDR TB. And then, of course, the MDR or any fluoroquinolone, that is called as pre-XTR. So the percentage again around 21.8%, that is fluoroquinolone resistance. And any isoniazide resistance again is very high. In the new cases about 11%, and for previously treated cases about 25%. So this is our national DRTB survey data. You see what then the country is doing. This is the evolution of our national TB program and the periodic updates in policy and guidelines for drug resistance TB. This is the overall picture of our national TB control program. That was in before 1992, 93. We had got only TB control program. Then you named it as a revised national TB control program. At various points of time, we have upgraded, we have revised our approach, targets and goals. Specifically for handling drug resistant TB, we called it as a PMDT, or a programmatic management of drug resistant TB. So you see, we started the DRTB services in 2007. Until 2012, our focus was establishing and expanding the services. Then between 2012 and 17, we have got the national strategic plan when we introduced the cartridge based and the other molecular based testing, introduction of the other like TrueNATs, nationwide coverage of universal drug sensitivity testing, Sutter MDR-TB regimen, and so on. This is how we progressed from 2007 and until now. So what is our national strategic plan between 2007 to 25? We have to prevent. The first important thing is, because as I told you, diagnosing it is difficult, treating is difficult, treatment outcome is difficult. So therefore, the focus should be prevent. Prevention is better than cure by ensuring airborne infection control at facility, access to effective TB preventive therapy, and programmatic management of the so-called TB sensitive case. I mean the sensitive TB cases. Then we have to detect all cases by early identification through quick and effective diagnostic methods. Then treating, expanding the treatment. Then whatever we are diagnosing, we must treat them, and then we must build by ensuring adequate funding, human resources, community engagement, and promoting TB research. So this is the main focus of our national strategic plan for specifically for drug resistant TB. As I think I was telling during the inaugural session that TB is just not a medical, it is just not mycobacterium TB and give INH rifampicin XYZ and the patient is cured. No, that is not that easy. So it was realized that the TB control has a wider dimension that is beyond clinical diagnosis and treatment. It has got a public health component where we need to give support to the patient. As you just saw, this is only one example. Giving nutritional support, just one example. Giving them financial support. Then engaging all healthcare providers. It is not only the pulmonary physicians are not enough. Then obviously the preventive measures by the society has to be involved. Then the social issues that we should empower the community. It should be, the approach should be multi-sectoral. As I told you, say for example, it is the community. What happens? There is overcrowding, there is housing, there is nutrition, all those things. So therefore, unless those those sectors are involved, so that our better socio-economic life. So TB obviously you are not going to eliminate. Then addressing the non-health determinants of TB. So this is just a multi-pronged attack. So the drug resistant TB to be tackled, we have these are the strategies. If you see the top one, that is in orange, that is prevention of drug resistant TB, as I have told you. Then strengthening and procuring the drugs, then nutritional assessment and supplement, improving adherence through counseling and support, regimen containing newer drugs, national drug resistance survey from time to time, so that you know where are we, what is the burden, and then obviously DST guided, the drug susceptibility testing guided treatment for all types of TB. So these are the important strategies for tackling drug-resistant TB. Now coming the first one, how to prevent the drug-resistant TB, it cannot be addressed by mere diagnosis and treatment of drugs. That is only, you are just fighting the enemy. We are not preventing, right? So the basic TB diagnostics and treatment service should receive priority, particularly the DAR strategy which is being done. The once a new case is there, it should be diagnosed and then treated. Then the system, there should be a system for early detection and treatment of drug-resistant forms of TB. It should be integrated into the existing TB services. Then healthcare facilities and congregate settings to focus on proper infection control measures so that it is not spread. Measures to prevent incidence and transmission of TB are also effective in preventing the drug-resistant TB. So the vision for DRTB case finding under the program, the second step is case finding the DRTB case. It is to provide early diagnosis to all persons with any form of DRTB through universal access to drug susceptibility testing, what we call now the UDST, universal drug susceptibility testing. Then rapidly identifying these DRTB cases, and this will be achieved by the combination of the CB-NAT or TrueNAT, that is a nucleic acid amplification test, then first and second line probe assays, liquid culture and drug susceptibility testing, then using a stepwise approach in integrated DRTB diagnosis algorithm. So you see, we have got detecting, we have got genotype test and phenotype test, as I have told you, and that you have heard about the diagnostic approach. And similarly, these are the methods summarized. Then we have got for the quick diagnosis, we have got expert MTB RIP. This is a cartridge-based nucleic acid amplification test. And then simultaneously, we detect the Mycobacterium TB as well as the rifampicin resistance. Then we have got also expert MTB XDR. Here it is a follow-on test to the molecular test. Here we detect the resistance towards INS, fluoroquinolone, second line injectables, and also ethanamide, right? This is XTR in addition to the MDR-TB. Then TrueNAT, which is a indigenously developed testing, it is a chip-based micro real-time PCR-based nucleic acid amplification. It comes in Uno, Duo, and a Quattro, and this is a point-of-care test. Again, it is a very useful test. And then we have got line probe assays both for the first and second lines. Here it is a PCR and a reverse hybridization is the principle, and it is interpreted based on the development and the absence of wild type and mutation bands. Then the solid cultures and obviously liquid cultures, you all know about that. So these are the various methods. So what the program has done, just to tell a little bit, that is increased access to diagnostic service. You see, if you see from the below, say for example, the microscopy center, we have got now one microscopy center at a population around 68,000. In 2017, there were around 14,000 microscopy centers in the country. By 2019, it is 20,000, and in 2021, it is more than 22,000. So the aim is that to have got the primary health centers and then to be provided with a laboratory technician. And again, on the right hand side, again you can see the rapid molecular testings. We have got these are the number of machines. They are available in 2017. We have got about 1,100. 2019 about 1,530, and now it is projected that we should have over. Now we have got over 3,000. It is about 3,100 plus, and then by 25 it is projected to be over 5,000. So they should be available, these machines, and they are available in the country. Again, you see the diagnosis of drug-resistant TB patients. Again, on the left-hand side, if you see, in 2009 to 2017, there is a rapid increase. Then the utilization of CB-NAT testing, this is the number of tests done per month. You can see about with the machine, the CB-NAT machine. So there is again a rapid increase. These are the scale up plans at the various years. How will we scaling them up? For the TrueNAT, again the same thing. the first line probe assay, second line probe assays. So all these things are being gradually scaled up. Then same thing about liquid culture, the machines. So the only issue is the detection of drug resistance and susceptibility can be done by utilization of these testings. So now let us see what is the status of drug resistant TB services in India. You see, this is a figure of second quarter of 2020. As you can see on the functional levels, I have already told you. Then the TrueNAT, then the different laboratories. We have got about liquid culture and DST laboratories 55. We have got the nodal drug resistant TB centers about 173, and then the district DRTB centers about 620. And on the right hand side, this is the number. So far, the MDR and the rifampicin resistance TB are diagnosed over 3,52,000. And then out of this, around 3,08,000 were put on treatment, and XTR TB diagnosed around 15,000. And then the INH resistant TB diagnosis around 40,000. So then, and then the question you can see over the years, there is a gradual, these are the suspects. The blue line shows the number of machines available. But again, you see, these saying these things seems very easy. But if you remember, I had told you what is the expected number of MDR TB cases. You remember, 1,24,000 I have told you. So how much we have detected? So it is way how I present you. If I say, we are just expanding, we are doing very well. No, we are not doing very well. Still, we are not able to diagnose 1,24,000 cases. Again, there is a gap. We are diagnosing, but we are not putting them on treatment. All cases are not able to get treatment. So, so these are the programmatic issues, and that need to be tackled. But I think this is what is the real situation. Then coming to the next issue, the other approach is the PMDT ensures it is a decentralized management of DRTB patients. I told you through the DRTB centers at different levels, the nodal centers at the district level, then availability of inpatient care, drugs, monitoring, all treatment regimens. Now we have gone into the new regimen. I will show you in a minute. Then we have got INH, mono and poly treatment to be initiated at the healthcare facility level. Again, now the further thing is added to further improve the quality of care. There is a difficult to treat TB cases that is called DT3. They are difficult to treat TB, that is T3 centers, clinics are established at state. So any case, if it is a difficult case, you are not able to know. So this can be done through them. And there is a patient-centric care. Both the patient needs, diagnosis, treatment, confidentiality, all these things are maintained. Then we have got a customized treatment. I will straight now come to the treatment services. What are the new regimens? You see, we have got nationwide network of DRTB centers. There is a treatment. We have a follow-up, pre-treatment evaluation, then selection of regimen, and then treatment may be initiated in the ward or in an outpatient basis. So it is a fully oral drug resistant treatment regimen is given. The main issue, if you understand, for the drug resistant TB, it is under diagnosis by missing TB cases, limited testing, linkages and capacity issues, and treatment is usually longer, it is less efficacious, and the complex in the management. The complexity in the management is the adherence issue, adverse drug reaction, and severity of the disease. So this is how is the flow it goes once the patient is diagnosed and how he is handled at the drug resistant TB center. Earlier, before these newer regimens, we are using these drugs, that is what we call as the DOTS plus or the category 4 treatment. They are those drug regimens. There are 6 drugs were given for 6 to 9 months with a injectable for about to that duration. And then during the then 4 drugs were given for the remaining 18 months. So the total regimen was 24 to 27 months, very, very long period with injectables, and these are the drugs and the regimens. I think many of you must be knowing that. But I think these things are now in the past. We have got now newer regimens. And then for XTR TB, again, there was a different regimen and it was slightly changed. Instead of injectable, we are amikacin and kanamycin we are giving. Capreomycin, PAS, Moxi, high dose INS, clofazimine, linezolid and amoxiclav. And then in the continuation phase, the injectables can be given for longer period. Then some of the drugs were taken off. So, you know, what was the result? At that time, obviously, under the research condition, the success rate was around 61%. That was when the first time it was done and supervised by the LRS, but that was in a research mode to see how efficacious this regimen was. So it was around 61%. But again, on the programmatic condition, you see over the years, when you are using those drugs as recommended by PMDT guidelines, you can see the green ones down below, it is always below 50%, 45, 46, 47 like this throughout. So obviously, and then around 20% of the patients will die during the course of treatment. Then another 20% they will be lost to follow up. They will not come, we do not know where do they go. And then there are failure rates, the regimens were changed. So but the basic point here you can see the less than 50% was the efficacy rate. So this is again not acceptable. Now you use the statistics, so many number, last we don't diagnose, don't treat, to whom we treat, you know, it is only 50% result. So out of 1,24,000, if you look, so actual treatment only 20 to 25,000 could be treated successfully. The remaining patients are, I do not lost to where. Then for XTR-TB, again you see the green ones, the success rate was around only 30%, 32%, not beyond that, right? The one only highest figure was 36%, so roughly it is around 32 to 33%. This is again a very, very difficult with those regimens which I have told you. So these are just a comparison with the Southeast Asian and then the world figure. So it is, we are slightly better in some extent and slightly not even worse in to some extent. Many Southeast Asian countries were doing better, and even we are almost same as that of the world figure. So WHO has got guidelines from different times, starting from 1996, and the latest one was the WHO guideline 2020. From time to time, depending upon the evidence, they provide us the guidelines. So these are the some key changes. To start with, there are interim policy guidelines, and then 2020 we have got consolidated guidelines which are updated, and then they confirm the safety and the new drugs available. So the 5 priority actions now, it is told that to address the global MDR-TB crisis is prevent the development of drug resistance, expand rapid testing and detection, provide immediate access to effective treatment. You remember every word is important, and proper care, prevent transmission through infection control measures, and increase the political commitment with financing. There should not be issue, this drug is not available, this test is not available, cartridge is not available. These are not acceptable. Then sustaining this thing is through a decentralized system that I have already told you. So now about the drugs, just a line, you see this is the development of drug pipeline. That is the first drug we have got in 1943 when streptomycin was the only drug. Then over the years till about, about in the 80s, early 80s or say late 70s, we have got rifampicin. Then after that for the 40 years or so, then we all slept, 35 years we slept, no drug, no discovery, no new drug. Then the TB Alliance was formed, and then in 2012, only Vidaquilion, the drug that of some efficacy, that came in, and then of course in after 2 years Digambar. And then these are the various drug pipelines. They are under trial because a lot of effort is being made to develop new drugs. But however, the market approval, we have got 3 new drugs, that is Vidaquilion, Digambar and a pretomanide. So these are the 3 important drugs, as I have told you, the Vidaquilion, Digambar, pretomanide. So Vidaquilion, it is a new class of drug and is mainly targets the mycobacterial ATP synthase. Delemanide is the first approved drug in the class of nitro-dihydroimidaxazole for the treatment of MDR TB, and it acts by preventing the synthesis of mycolic acid in the M. tuberculosis. So these are the doses. Vidaquilion is now approved for 5 years and above, and weighing at least 15 kg, and this is the dosage given 15 to 29 kg, initial 2 weeks 200 milligram daily, next 22 weeks 100 milligram 3 times a week, and more than 29 kg, initial 2 weeks 400 milligram daily, the dose is double actually. Then Delemanide, it is approved in India for 6 years and above, 6 to 11 years 50 milligram BD, and 12 years and above 100 milligram BD. You know, now recent data of WHO says that there are no additional safety concerns when you are using concurrently Vidaquilion and Delemanide. They can be used concurrently, because earlier there was some concurrence of cardiac toxicity. Then of course we have the repurposed drugs, particularly linezolid and other drugs injectables. So we have got this Indian guideline for preventing management of drug-resistant TB. You see, we have got now, this is the latest guideline, these are the latest regimens. The standard drug-resistant TB regimen under our program is that we have got 3 different types, that regimen for INH mono or poly drug-resistant TB regimen, then Sutter MDR or RR TB regimen, and longer oral MDR XTR TB regimen. Now seeing about INH mono resistance, because it is very important, you see it has been seen that INH mono resistance, you can see success rate even while we are using the earlier ones, it was only 31% with a high failure rate of 49%, and it progresses to rifampicin resistance or MDR TB in around 40% of cases. So it is very important that INH mono resistance is to be taken very seriously. So here the regimen is, it is 6 or 9 months of levofloxacin, rifampicin, ethambutol and pyrazinamide. Duration of this regimen is 6 months. It can be extended directly to 9 months if the patient has got extensive disease, there is uncontrolled comorbidity, there is extrapulmonary TB, if smear at the end of 4 months is positive, and when the regimen is modified. It can be extended up to 12 months in CNS, skeletal and miliary TB, and then the use of new drugs like Vidaquilion and Delemanide are not recommended in the INH mono or poly regimen, right? The other regimen is fine. Then this is, as I have already told you, when it can be extended. Then there is a replacement sequence. If any one of the drugs cannot be done, then there is a definite replacement sequence. And this is how one has to approach for the rifampicin. Any new case, we do a NAT test. If it is rifampicin, then you see when there is a INH resistance, you have to go for that test. It may be either rifampicin resistant or rifampicin not resistant, and then you go for the INH testing through the LPA, and where you can get whether there is INH resistance or not, and then accordingly you do the treatment. However, the ATS guideline, remember this is not our country guideline, because since there are the postgraduates are here, so this is a ATS, American Thoracic Society guideline. They say that in patients treated with a daily regimen of a lateral generation of fluoroquinolone, rifampicin, ethambutol and pyrazinamide, the duration of pyrazinamide can be shortened to 2 months in selected situations, like if there is a non-cavitary disease, if there is a lower burden of disease, or there is a toxicity from pyrazinamide. But again, remember, again I reiterate that pyrazinamide is to be given throughout in Indian guidelines. So this is the WHO treatment guideline. So we have got till May 2020, over 23 patients have received this regimen. Sorry, it is again repeat. Now coming to the Sutter MDR and rifampicin regimen, we have got 2 forms, of injectable and all oral. Fortunately, after 2 days, this injectable will be taken off. So it will be, now the entire country will receive all oral Vidaquilion containing regimen. So I think I will skip the injectable one because it is no more going to be used after 2 days. But here usually this was based on the Bangladesh regimen when they have used this drug for minimum 9 months and they are giving gatifloxacin, clofazimine, ethambutol and pyrazinamide throughout the treatment period. It was initially supplemented by prothionamide, kanamycin and high dose INH during an intensive phase of minimum 4 months. You see, with this regimen, there is a relapse-free cure rate of nearly 88% among 206 patients. So then the interest came with the so-called Bangladesh regimen or the short course regimen. And then it is not only that, in many, this is a meta-analysis just published in different countries. This has been approved from Bangladesh, Benin, Niger, Cameroon, 9 countries in West and Central Africa, Ethiopia, all those things. These are cohort studies and the randomized controlled trials. They all say even short course chemotherapy is equally effective. So this is a concept that had come. So then, when the Vidaquilion conditional access program, they came in, Vidaquilion drug, I told you. So this was introduced, it was launched in 2016 on 6th June 2016, and then it was rapidly expanded. And as I told you, from day after tomorrow, the injectable regimen will not be there. Similarly, this is the Vidaquilion, how it came from December 14, and we have come a long way, 7-8 years it took us. Similarly, Delavan ID also. So the short injectable containing regimen, since it is no more going to be used, I will just skip that. What was the inclusion criteria was the MDR TB without fluoroquinone resistance, all extrapulmonary TB except disseminated miliary and meningitis can be given to children with children and people living with HIV. It is excluded in pregnancy, extensive pulmonary TB and other issues. The regimen consisted of 9 to 11 months of intensive phase, 4 to 6 months of high dose moxi, pyrazinamide, ethambutol, clofazimine, kanamycin injection, ethionamide and high dose INH. And then the next 5 months, the 2 drugs are taken up, the injectables and high dose INH and ethionamide is taken up, and moxifloxacin, pyrazinamide, ethambutol and clofazimine are continued. This was the injectable containing regimen. So this is a package of this was, I should say, even as today it is still disease, it is a package of treatment. If any drug needed replacement, then switch to all oral longer regimen. This is again another study that shows the efficacy. It is whether you do the conventional one, the efficacy rate around 78-79%. So it was very efficacious. Even other countries, the same thing I have already told you. This is the regimen we saw. Then even our own country, this injectable regimen that shows a very, in the rate that shows the success rate of 68%. This is obviously a dramatic improvement from less than 50%. So it had worked well. I don't know, there is repetition. So now coming to the oral Vidaquilion regimen, which will be now the shorter regimen for this country. So this is a shorter oral Vidaquilion containing regimen for MDR and rifampicin resistant TB. It is 9 to 11 months. So the initial phase will be 6 months of Vidaquilion and then the remaining 4 to 6 months of levofloxacin, pyrazinamide, ethambutol, clofazimine, ethionamide and high dose INH. And in the continuation phase, the Vidaquilion obviously will not be continued after 6 months. And then the ethionamide and INH are taken up, and the 4 drugs, levofloxacin, pyrazinamide, ethambutol and clofazimine will be continued. So thus it is becoming 9 to 11 months of therapy. The shorter oral Vidaquilion containing, it was started with the 7 states. These are the states, but again from 25th March 2020 onwards, it will be expanded to all parts of the country. So these are the inclusion criteria. It is a RR resistance or MDR resistance. The other inclusion, children can be given, I was told you. Then no history of exposure to previous treatment with second line medicines. no extensive TB disease, no severe extrapulmonary TB, women who are not pregnant or lactating. You should exclude when there are H resistance in addition, and they have got both CAT-G and INHA mutation, and MDR rifampicin TB patients with the fluoroquinolone resistance detected, and there are also other exclusion criteria. For Vidaquilion, obviously, if the patient is having uncontrolled cardiac arrhythmias, and this is how one should go. If you do the testing, suppose you detect there is a rifampicin resistance, then the second specimen will be tested at the culture and the DST lab, and then this specimen will be subjected to first line LPA to find out INH resistance, and second line LPA will be done, and also liquid culture will be done to find out resistance to pyrazinamide, Vidaquilion, clofazimine, moxifloxacin, linezolid, and delamanide. And then after completing the pre-treatment evaluation, you check on the NICA or with culture and DST lab if LPA results are available. If it is available, yes, and there is no additional resistance detected, or INH resistance is detected with CAT-G or INH mutation, but not both, and fluoroquinolone resistance not detected, then straight away put Sutter oral Vidaquilion containing regimen. On the other hand, if there is no, if these tests are not available, use other exclusion criteria for Sutter regimen. If they are absent, obviously go to the oral Vidaquilion regimen. If they are present, you have to go for longer oral regimen. When you are doing, you find out the resistance to any one of those drugs in the second line. If INH resistance is detected with both CAT-G and INH mutation, or fluoroquinolone resistance is detected, then obviously you have to go for longer oral regimen. So this is how one has to do, and it is a very simple, algorithm. These are the treatment outcomes. The success rate is around 81%, even with this regimen. And you see, with the use of this Sutter MDR TB regimen, you see how our success rate has increased from less than 50% to nearly 70% or so. And again, it is not only our own country data. You can see this is again a forest plot. You can see many other trials also have shown successful rate of 70 to 87% of success rate. These are different publications I am trying to show you. The last one, coming to the longer oral regimen, you see the unfortunate part of this regimen is these are actually not based on direct, as usually we do phase 3 clinical trials. They are not done because of the emergency. So this is called the individual patient data, or the Ipd data. This was a meta-analysis over 12,000 patients. They have tried to see which drug used in which country, and our country was also involved. The study from PGI and from AIMS and Bombay, there are the 3 centers there. Our data was also taken into that. And what they say, that although inferences are limited by these are observational study, again as I told you, treatment outcomes were significantly better with use of linezolid, later generation fluoroquinolones, Vidaquilion, clofazimine, and carbapenems. These findings emphasize the need for trials to ascertain the optimal combination. So based on this, and then these are only, as I was telling you, they try to assess with the use of these drugs, what are the chance of death, and what are that is the side effect of serious adverse event, and the success rate. So based on that, they rated the drugs. That is how the basis of newer classification of drugs used for drug-resistant TB. So they group them into 3 based on this data, based on the how quickly or how many of them lead on to more death, and how many of do to more success or better success. Based on those, that chart I showed you, they divided in 3 groups. Group A drugs include all 3 medicines, that is a fluoroquinolone, Libo or Moxi, Vidaquilion and linezolid. These 3 are the best drugs. Then group B, add 1 or both, that means they are lesser than group A but still better than group C drugs. We have got clofazimine, cycloserine or terizidone. And then to complete the regimen, the other drugs can be used. They are called group C drugs, that is ethambutol, delamanide, pyrazinamide, and then imipenem, cilastatin, meropenem, amikacin or streptomycin, ethionamide, pythionamide, para-aminosalicylic acid. Please note here, kanamycin is up from this list because again it produces high death rate when they did this IPD meta-analysis. So this drug is not there, did not find a place. So this is, so what we saw, the group A drugs, fluoroquinolone, these drugs, they have a greater treatment success, they have a reduced death. Then the second group, that is clofazimine, carbapenems, greater treatment success, but no reduced death. Then pyrazinamide, lower mortality if it is susceptible. Streptomycin, amikacin, cycloserine, pterygium, they have got modest benefit. Kanamycin and capreomycin, they are higher failures, relapse, death and toxicity. So they are no more recommended. Then the other drugs, they have got no significant benefits like ethionamide, PAS, macrolides, amoxicillin, that combination, etc. So these are based on this. This is what is the basis, and this is what is the same thing again here written in this form. So what should be the strategy? So build a regimen. These are the basic principles. Build a regimen using 5 or more drugs to which the isolate is susceptible, preferably with drugs that have not been used to treat the patient previously. So therefore here comes the importance of taking a history from the patient, which most often we forget. What clinical, examine the patient clinically, take the proper history. Then choice of drug is contingent on capacity to appropriately monitor. Then preference values, as you can give, as I told you. So the best thing is choose one later generation fluoroquinolones, then choose both of the prioritized drugs, Vidaquilion, linezolid. So all 3 drugs preferably are to be used. Choose both of these prioritized drugs, clofa, cyclo, or pterizidone. Then if a regimen cannot be assembled with 5 effective oral drugs, then go to the to the group C drugs. The first preferable will be amikacin, streptomycin if they are susceptible. That again one condition. If needed or if oral agents preferred over injectable agents, then use delamanide, pyrazinamide, ethambutol. And if limited options and cannot assemble a regimen of 5 effective drugs, consider use of the following drugs in order of merit, other drugs, but they should be less preferred drugs, right? So these are the basic principles how to, so this is as per WHO recommendation, I have already told you. However, in India, the experts concurred to start with all 5 drugs of group A and B, which I have shown you, and continue with 4 drugs in the latter part of the regimen beyond 6 to 8 months if the patient can tolerate the drugs and for operational cases in the field, particularly linezolid, because you may have to reduce. So this is what is the regimen, that is 18 to 20 months of levofloxacin, Vidaquilion, 6 months, it can also be given longer, linezolid, clofazimine and cycloserine. So these are the 5 drugs. You must remember for the longer oral regimen, the duration is 18 to 20 months. Vidaquilion will be given for 6 months and can be extended beyond 6 months as an exception. Linezolid 600 milligram for 6 to 8 months, then reduce the dose because of the side effects. And for XTR-TB patients, the duration of longer oral XTR-TB regimen would be for 20 months. So, ladies and gentlemen, I should stop here, but I have exceeded my time. So what I have tried to tell you, I tried to give you a brief overview about the issue of drug resistant TB in this country,